I'm going to talk to you about some things related to automated cell counters, and I won't just focus on. I'll focus mostly on the thing that I'm really interested in, which, if you know by now, it's mainly around iron deficiency and how our machines can actually give us the most valuable information possible. But I won't just focus on that. So I do have some declarations. Basically, there aren't any. Okay, I have done some work previously for an iron infusion company called B4 Pharma, but nothing recently. So what I'm going to cover today is, I thought I'd take a bit of everything just to show the chemists that we don't just do one test, that actually our test can have clinical applications. And one of the things which I'm excited about, which drives us forward, is that, okay, we do a full blood count, but ultimately, how can we use some of the things that blood count tells us to clinically impact on patient care? So I'll do something on the white cells, something on platelets, and then I'll focus more on the red cells, if that's okay. So let's go straight on. So recently I heard about an analyte, which is basically extrapolated from the monocytes. It's called the monocyte distribution width. If you've got a Beckman-Coulter, one of the newer Beckman-Coulter machines, I don't, but if you do, then you know that you can get a distribution width related to the size of those monocytes. And a study was done very recently looking at whether that could be used in patients who've got potential sepsis. What they showed was that if the monocyte distribution width is high, that's suggestive alongside other markers that this could be an early indicator of sepsis. So what this struck me was that this is something using the data that we already had related to perhaps those research parameters that are coming out from the machine. You get a number, but ultimately behind the screen, we can extrapolate sizes, complexities, and using that information to maybe help with patient care. So it's a new biomarker as such. The difficulty is that with every development that you make, you have to make sure that you're giving the right information. So one of the things that I'm really keen on, and you should be really keen on, and I know you are, is that everything you report has to have in the background that quality assurance around it. So one of the things which NEQAS obviously is doing is part of that. It's related to making sure that as external quality, that we provide you with that confidence, the results that you're giving out relate to a quality backbone. So you may be able to report this, but in reality, if you can't externally quality assure it, then there's always that caveat. And certainly for UCAS purposes, that would only fall into scope if you had that quality assurance scheme behind it. Otherwise, it's out of scope, it's research, but the truth is that shows us that even things such as simple monocytes, we can get some valuable information from. The IPF, I'll just move on to platelets. The IPF has been around for ages. I remember hearing about it 15 or so years ago. And you can extract the information related to Sysmex and Abbott. They've got slightly different names, but essentially these are reticulated platelets. Probably the best thing to do is think of them as early platelets or young platelets. There is limited clinical utility, despite the fact that a few years ago we were thinking, yeah, okay, maybe we can use this information. I think we still need more studies, but again, exciting that we can use the information coming out from our machines potentially to give us some clinical benefit. It was thought perhaps that IPF could be used to maybe limit the platelet transfusions in patients post-BMT. If you saw that there was an early rise, despite a low platelet count, you might well avoid giving that platelet transfusion if it's around your sort of cutoff. And maybe potentially using it in a differential diagnosis, perhaps ITP versus aplastic anemia. Because of course, both might be anemic anyway, because ITP with bleeding or aplastic anemia because of bone marrow failure. There are going to be other analytes you could use, for example, the reticulocyte count, but ultimately gathering as much information as possible is always the way forward. So moving on to my key thing that I'm always interested in. What I'm going to do is just going to go through a quick overview with you about iron deficiency and how the machines work and what exactly we can get from them. But then I'm going to give you some clinical cases so that you can see the sort of numbers in action. So really, the laboratory diagnosis of iron deficiency cannot sit in isolation. It has to be related to a clinical picture. And that's essentially what I teach my medical students and my junior doctors as they're coming through the laboratory, that you can't do one without the other, but hopefully you can get one to a better level that you can use that more clinically, in a more clinically relevant way. Now, the problem with iron deficiency is that it's not easy. Anybody who tells you the diagnosis of iron deficiency is easy is wrong. It's not easy. And the problem is because there are so many other things that impact on how we mobilize iron throughout the body. And it's mainly down to this crucial thing called hepcidin. Now, hepcidin is there for our benefit. It is there and upregulated in infection inflammation because it's trying to tell your body, don't let those bugs that are invading your body get hold of the iron as well. So it blocks the ingress of iron, but it also blocks the utilization of iron, the mobilization of iron from the macrophages into developing red cells. So the implication is if there's infection or inflammation, it's trying to develop the same sort of picture that you would have if you don't have enough iron. Okay, the analytes, all the other things are maybe different. There might be some inflammatory features, but ultimately the endpoint is the same. It's trying to reduce the utilization of iron. So that's, this is a rather complex slide, but essentially it's just telling you that hepcidin interacts with how we mobilize iron around, and it helps us to understand this phenomenon of absolute versus functional iron deficiency. So how do we know that we're getting our tests right? What tests can we use? Are they readily available? A good example is soluble transferrin receptor. Can you do it? I know I can't. And I know if I send it away, it takes a long time to get the result back. And of course, it said, okay, that's the gold standard. But what about in hemolytic anemias? We know that it can be altered in that as well. So individually, what is the clinical utility? It's all very well, but at the end of the day, it's trying to get those tests done at close to the point of care of the patient, because the minute you remove that, you've got a time delay, you've got things that could come along to distract you from that management. So if you can get a test done locally that has clinical utility, I would imagine that's the best way forward. So many of the tests that we do, we can say, okay, they can be helpful in the diagnosis, and we can divide them into our sort of classic hematology tests, sort of chemistry and immunoassay tests. But I'm going to focus on the hematology ones, obviously. So there is, for your information, there's a new guideline which has just been, well, it's hopefully going to be published very soon. It's out as an e-publication at the moment, but it's going to be published in the British Journal of Haematology by colleagues from the British Society of Haematology Guidelines and Guideline Group, and it's related to how laboratory diagnosis can be made in adults and children, excluding pregnancy, because we have one related to pregnancy already, but that one should be published anytime soon in the British Journal of Haematology and will be on the BSH guidelines page when it comes out. So, what are the main issues? Well, the problem is that we know that there is a point at which below ferritin, that's barn door, that is going to be absolute iron deficiency. But somewhere above that, you've got adequate stores moving into inadequate stores that aren't quite sufficient enough to meet the needs of the hemoglobinization of the red cells. Where is that cutoff? Well, it's quite variable. Most people would say it's somewhere around 30, 45. A good way of thinking about it is, well, if it's above normal, probably isn't absolute iron deficiency. But putting an arbitrary cutoff is actually not evidence-based as such. We know that there was some data related to some gastroenterology studies done recently, which suggested about 25, but in all fairness, it's not clear cut. What we can say is that probably If your serum ferritin is less than 15, on balance, most of your stores are depleted. You are into the realms of depleted iron stores. And some phase above that, you're beginning to deplete your stores, and maybe anemia has not quite developed yet. And anemia is more likely to develop in that setting of depleted iron stores. You add infection, you add inflammation, and of course, that serum ferritin no longer becomes reliable. So what we certainly incorporated into the anemia chronic kidney disease guidelines, which was published in June 2015, was this idea of iron restriction with a normal serum ferritin, particularly in CKD, such that your ferritin level no longer became a threshold for you giving iron, it became a threshold for where you probably wouldn't give iron. So essentially, if it was supranormal, if there was evidence of iron restriction, you would still give intravenous iron, which was slightly different to how it was phrased in previous guidelines. We know that the serum ferritin is the hallmark for iron deficiency, and that 1 microgram per litre is equivalent to about 8 milligrams. So if you do a little bit of maths, if you know what your serum ferritin is, you could probably multiply by 8, and that will tell you how much iron roughly. If you're normal, there's no evidence of infection or inflammation. It's a very old study, but it was done on normal volunteers. And of course, you know, my chemistry colleagues would definitely agree with me. We need to make sure that each of our ferritin assays, new ones, old ones, are related to an international standard. So how do we go about making that diagnosis of iron deficiency? Well, if you read the books, it'll tell you you need to suspect it with a microcytic anemia. And then this is where it starts to get a little bit sort of head in your hands job. The whole idea is, and you know, you will come across it, and I come across it all the time with my medical students. I don't get them in the early years, I get them in the later years, and I say, you know, what's iron deficiency look like? And they'll say microcytic anemia. And no, it isn't. You know, no, it isn't. That is the one which is more specific, but it is not sensitive enough. Most of the people that we will see with iron deficiency have got a normocytic anemia, because in real life, we've done studies. If you look at people who've had a blood count done and they are quite clearly iron deficient by the nature of their serum ferritin, you look at their blood count, and this is what you find. You find that they are anemic, so their peak is below the 120. You look at the MCH, and the normal range for here is 28 or above. So there's a peak, it's below. Okay, you don't need to do fancy stats. The peak is below the normal range. Look at the peak here in the MCV, it's in the normal range. So there's clearly a disparity. There's difference between the MCV and the MCH. The MCH is telling us one thing, like microcytic, and the MCV is telling us another. It's normocytic. Now that shouldn't come as a surprise to you, but it does come as a surprise to many people. It's not unique to Sysmex either. When we look on the Sapphire, when we look on the Alinity, we're seeing exactly the same picture. It is that the majority of people who've got a serum ferritin below threshold of normality, they start with a normocytic anemia. And really, that's when you need to diagnose them, because that's when there may well be a pathological process which you need to know about. Now, that might be that it's slightly different for, say, Hb, but without doing the studies, without actually looking at it yourself within your own population, how are you going to know? It doesn't seem to matter if you change the normal range either. We've done a lot of normal range studies, and actually the normal range is still the normal range, down to 80 femtoliters. It's normal for the normal population. But that would appear to be the same. The majority of people who've got iron deficiency are still within that group as well. So microcytosis is a much later development in the iron deficiency pathway. So we still need to suspect it. So you still need that clinical picture. You can't just do a blood count and say, okay, blood count's normal, can't be. You still have to marry it up with a clinical picture. And I'll show you a little bit later where we've done that very recently. BSG produced some new guidelines around iron deficiency, which I was really pleased to be involved in. And a lot of that is talking about using some common sense, using the clinical picture as well as the laboratory picture. If you look at people who've got a diagnosis of bowel cancer, what we see is that in the sort of timescales, 6 months or above, less than 6 months, we find that hypochromia is dominant, whereas microcytosis is not. And these are people who've got a diagnosis of a bowel malignancy. That group of people where the anemia is because they are losing iron from their body, because they are bleeding. That is why they are anemic. So the blood picture is quite clearly representing that process. So if it's saying the majority of people are normocytic, then not only is it in iron deficiency for the other causes, but it's in iron deficiency in people who've got bowel malignancy. So it's telling us the same thing. And if you look, that before ever they get mostly referred, that actually they're normocytic in the vast majority. Then they become a little bit more microcytic. Presumably then they're diagnosed, they're given iron, and then some of those will respond and the microcytosis will actually disappear. So what does it suggest? All anemic patients need a serum ferritin, basically. You can't just look at the MCV, MCH and just say, nah, it ain't iron deficiency. You need a ferritin. But we know, and you know, that serum ferritin is done predominantly when there's microcytosis. But actually that misses the point. The MCH is much better at picking it up. But the trouble is it picks up the anemia of chronic disease. And that's a difficulty. But I would argue, if you've got a chronic disease that's causing anemia, you should know what that chronic disease is. Now, the difficulty there is chronic diseases, and then they got iron deficiency. Well, ultimately, it is still using the clinical picture with the tests that come along. CRP might help if you're thinking, okay, I can use the ferritin alongside CRP. Yeah, that can help. And then that's building that picture of the clinical picture, the laboratory picture. So what about reticulocyte hemoglobin? Well, certainly we incorporated it into the June 2015 NICE guidelines. It was in there already, but mainly focusing on percentage hyperchromic cells, which if you've got a Siemens analyzer, you'll know that that's only reliable if you can get it into the laboratory within a couple of hours of actually taking the blood out of the patient. And in addition to that, if you can't exclude the carriage of thalassemia, well, you know that if your MCH is low, that's either a problem with heme or it's a problem with globin. Well, thalassemia, hello, that's a problem with globin. So you're going to get a low MCH, and therefore you're going to get a low reticulocyte hemoglobin in people who carry thalassemia. So you can't use the reticulocyte hemoglobin if you carry thalassemia. Well, not the RET-HE, not the CHR, etc. So the easiest way of thinking about it, well, what harm are we going to do? And that's sort of developing clinical base, really. Ultimately, for people who've got, say, for example, genetic hemochromatosis, if they're otherwise well and they've got normal liver function, we probably don't need to venisect those people until they've got ferritins over about 1,000. So if somebody's got a ferritin of 300 and they are significantly iron restricted, and there's a good reason for it, and they're anemic, then what harm will you do by giving them iron when you could actually make them less anemic? And that is what we do with CKD. We say that, okay, as long as it's less than 500 in the ones that are not on hemodialysis, you can give intravenous iron if there's evidence of iron restriction, and up to 800 if they're on hemodialysis. So it's actually helping to provide iron support, which ultimately helps them to not get further iron restricted, or actually that EPO have the best chance of working in patients with chronic kidney disease. Because if they're iron restricted and you give EPO, it's not going to work so well. They need to have adequate iron stores or adequate mobilization of iron. So if you're a Sysmex user, you can do the reticulocyte hemoglobin equivalent, Siemens, percentage HRC, hyperchromia, or CHR, and Abbott is MCHR. Much of the sort of historical evidence comes from CHR, which was pretty much the first development of the reticulocyte hemoglobin, but all of the other manufacturers have come along with their own tests now. I personally wouldn't use percentage hyperchromia. And ultimately, if you've got access, and if you've got somebody who's anemic, you need a reticulocyte count, don't you? You need a renal function. You need to know what that feedback loop is related to. There's anemia. Surely to goodness, the body knows there's anemia. It's detecting the anemia. What's it doing about it? So what's the kidneys doing? What's the bone marrow doing? Well, the reticulocyte count is an answer to the question of what the bone marrow is doing about it. So if you're doing a reticulocyte count, you're going to get a reticulocyte hemoglobin. Great. So that will tell you if they're iron restricted or not, provided you can exclude carriage of thalassemia. So studies have been done. If you don't know anything about ROC curves, don't worry. All you need to know is the further to the top left something is, the better it is. I hope that's true. Anyway, guess what? The pink one is MCHR. So just like we said in the NICE guideline, the predictive capacity of the reticulocyte hemoglobin is better than transferrin saturation, for example. And that's the same thing, say, for reticulocyte hemoglobin against, say, MCV or MCH. It's got better specificity, sensitivity in combination. And we can see that there are ranges that you can develop. This is from Eloisa Urochaga and colleagues. You can see that there are range differences. You can see that most of these people have got an MCHR, which is less than 29. And likewise, for a reticulocyte hemoglobin equivalent on Sysmex machines, you can see that there is good statistical evidence that people who are iron restricted, who've got absolute iron deficiency, have got different or lower MCHRs and RET-HEs to the normal population, because they are iron restricted, and therefore the reticulocytes, being that 5-day window of insight into the bone marrow, allows you to just concentrate on that very short window that are just coming out from the bone marrow. So that is not looking at all of them, so it's looking at a discrete population, but also it's a shorter period of change, isn't it? So if you make a change, you can actually look at that value. So Carlo Brugnara, for example, did a fantastic study, just a small number of people, looked at what happened to the CHR over a period of days of giving oral iron. You could see that the CHR goes up within a few days of giving oral iron as a response. The hemoglobin takes a little while to come back, but the CHR starts going up. And we also know that if you do in exact same time, I can't go into how we managed to do this because one machine was in Truro and one was in Plymouth. If you know nothing about the UK, they're not next door to each other. And we ran them at exact same time. We did CHR on one, we did MCHR on the other, and actually they're pretty well correlated, aren't they? So they do correlate with each other very well. This is the guideline that I mentioned to you earlier on about from the BSG, and that has been published. You can find it as open access. It has many of the things that I've already talked about. It talks a little bit about how we use the clinical utility of the tests that we could do. It obviously focuses a lot on the endoscopic diagnosis of iron deficiency anemia in adults, but I was very pleased to be involved in it. So yeah, it's out there. So the next question comes along is, okay, fine, we've got these analytes, which you would say are research only parameters. There's a lot of data out there, but how do we quality control? Because if we want to report this, we need to have an overarching quality assurance around it. Well, we've just completed a pilot survey related to the reticulocyte hemoglobin with colleagues at UK NEQAS. We sent out 3 samples to multiple laboratories that had Abbott, Ariba, Siemens, Sysmex, Beckman Coulter, and got data back, and we've had a brief look at the data. The 3 samples, they were basically bags of blood. One was from a patient who's got polycythemia, who's on the borderline, just a little bit hypochromic, my patient. Another one who was what you would call barn door iron restricted polycythemia, and another was a normal donor from the National Blood Service. So I'm going to show you the results from the barn door iron restricted patient. And so what you can see here is that these are the individual machines. So this is ABBA, MCHR, this is Hariba, RHCC, this is CHR, and this is Sysmex, Reticulocyte Hb. Now, they're all below 29. 29 is probably the cutoff. So that says that every single machine said this was iron restriction. Not only that, you can see that over a period of days, day 1, day 3, day 5, up to day 7, it stays pretty stable. So it's saying the same thing on day 7 as it is on day 1. Now, if you're going to do a QC scheme, you don't really want it to change if it takes, say, 3 days to get to you versus it taking 1 day to get to you. So it's going to say the same thing. So that's quite exciting, really. And if we just plot out all of the results together and we say that 29 is the cutoff, every single machine said this was iron restriction. So that's really pleasing to see. So the next steps, well, we've got the data, we're going to obviously write a paper, submit it, publish it, and then ultimately, as with all of the developments that we're involved in, if we can then formulate that through to a full program, then that will be ideal. And that will allow you then to add this test to scope under NEQAS so that you can report it to your users, particularly for the renal teams that will want it. Maybe it's for the pre-anesthetic, pre-operative optimization teams that would want it as well. And I'll come on to that briefly in a minute. So I'm going to talk about some cases where we now apply the things that I've talked about, our knowledge base, and how it changes what we do. So this is a 27-year-old lady. She started her periods at the age of about 13, said to be normal. She's never been pregnant. She doesn't eat red meat. She eats vegetables and fish. And she's got a BMI of 42. She feels tired and she's anemic. Now, let's think we're a junior doctor. We're going to look at the anemia. We're going to go, yep, she's anemic. It's less than 120. MCV's normal. Okay, I might do a ferritin. Oh, I've done a ferritin, it's 42. You'll stop there. This is a normocytic anemia with a normal serum ferritin. I don't know. You'll throw your hands up and go, I don't know. But we've got some more things. We've got an MCH, it's low, so she is hyperchromic. We've got a CRP that's a bit up. So maybe that's sense checking the serum ferritin. But what is that CRP actually telling us? Well, to be honest with you, if you look at CRP correlated with hepcidin, what you'll find is that they probably do go up at the same time. So if you've got high hepcidin, are you going to respond to the oral iron, or is it just going to go straight through and come out the other end? Probably the latter, okay? The MCHR is low, so she's iron restricted with apparently normal stores on the basis of the ferritin. So what we do know is that actually, surprisingly, if you look at blood counts in obese people, you'll find that iron restriction is surprisingly not that uncommon. And it's possibly because of this sort of pro-inflammatory state that obesity creates, where you do get an upregulation of hepcidin. Now, in a woman of this age, you're probably not worried about bowel cancer, but if she's got bowel symptoms, or if there's a positive family history of young malignancy, then you do need to think about it, especially if you go on to do the next thing, which is give her oral iron and see if she responds. So give her oral iron and see what happens. Now, the giving oral iron is, if you read the BNF, don't. But, you know, if you go to, you know, the page that you want, look up what you give. So you give ferrous sulfate 3 times a day. That is a very good way of finding out how people can be intolerant to a medicine. So don't do that. Give it once a day. And reduce it to alternate daily if there's intolerance. And then check a few weeks later. No more than 4, but check a few weeks later. Well, unfortunately, of course, this lady was intolerant to oral iron. And hemoglobin didn't change. So we gave her Ferinject because she's iron restricted. She's got an apparently normal ferritin. We probably know that because she's got an uprated inflammation, she probably won't absorb it orally anyway. So give it intravenously, flood those transferrin receptors, get the iron taken up, and lo and behold, she responds. So now the MCV is still normal. MCH is coming up. Serum ferritin, of course, is higher than it would be 6 weeks later. You often get a peak about a couple of weeks later after intravenous iron, and then it seems to stabilize. So, don't get frightened if you do a ferritin a couple of weeks after somebody's had intravenous iron and go, oh my goodness, because it's going to be high. Okay, so she's responded. This is a lovely lady. She's 79. She's got a long-standing history of angiodysplasia at the back of the bowel. She's also got platelet function defect. We call that a double whammy. Okay, so it's not great, really. But in October, she comes in. She's got a short history of dark stools, and she's anemic. What a surprise! Her MCV is normal. Her MCH is also normal, and her serum ferritin is 37. So look at that: normal chromic, normal cytic anemia. Just give her some blood. Normal ferritin. So she's discharged home with a plan for repeat endoscopy as an outpatient. It's not unreasonable. Shall we look at some other results though? So her reticulocyte count is 220 and her MCHR is 27. So she's got a fantastic reticulocyte response and she is iron restricted. It doesn't take a genius to work out what's going to happen next. If she's already making loads and loads and loads of red cells and she's already iron restricted, she's going to run out of iron, isn't she? So yeah, she did. She came back in 1 month later and now she's quite significantly anemic. She's still got a normal MCV, maybe because of the reticulocytosis. But her MCH is 26. So those reticulocytes are pretty poorly hemoglobinized. Now, serum ferritin is still normal. So what do we do this time? Well, it's going to happen again if you just give blood. This might say it's normocytic anemia, and the serum ferritin's normal range. She's going to run out of iron. And so what she got was essentially about 2 grams of iron. So 2 units of blood give you about 200 milligrams each, and 1.5 grams split over 2 weeks. And now her hemoglobin's 131. MCV has gone up, unsurprisingly, and our MCH normal, retics pretty good, MCHR normal. Serum ferritin has gone up still. It did peak quite high, but it's plateaued down. It's just about in the normal range. And she feels great. Now, this is a slightly different case, highlighting one of the issues. So this is a 47-year-old lady. She's feeling tired. She's mildly anemic, 112. Her red cell count is at the upper limit of normal. That's a bit of a clue. Her MCH and her MCV are pretty low. MCHR, accordingly, also low, unsurprising. Serum ferritin, 32. CRP is less than 1. So there's no evidence of inflammation. And I'm not telling you some things. So you look at those results and you're thinking, yeah, okay, this is a hypochromic microcytic anemia with a normal-ish ferritin. Fine. She's a carrier of alpha thalassemia, so that's going to affect the MCV, the MCH, and the MCHR. She's got pretty heavy periods. She's intolerant to oral iron. Transferrin saturation is low, it's 11%. So now we've got an alternative marker to say, okay, she's not trafficking a lot of iron. So your transferrin saturation just tells you at that point in time how much iron is being trafficked around, either being absorbed through the gut or being mobilized from the macrophages into the developing red blood cells. So it's low. So she's not moving a lot of iron around, even though apparently she's normal iron stores. So she's intolerant to oral iron. Well, she got IV iron and she feels better. Serum ferritin's up to 290. The difficulty here is that there's not much of a change of her hemoglobin, but she feels better. The difficulty particularly with iron deficiency without anemia, there's not an awful lot of evidence to say that people do significantly feel better. The ones who've got the worst performance scores do feel better. But if you feel a bit mildly not well with a normal hemoglobin with a slightly low iron store, the evidence isn't great. So, very difficult to justify giving intravenous iron. But more give lower doses of iron, give the iron which you could at least tolerate, not 200 milligrams 3 times a day. So what do the cases really highlight? It just highlights to you that your machines, your analyzers, they are capable of giving us that additional information to the clinical picture to say, is there iron deficiency or is there iron restriction? You know, and is it appropriate to give iron? And answering those questions often relate to what's the evidence base? What do the guidelines say? And, you know, does that mean I would be encouraged to give oral iron? Does that mean to say oral iron may not work? Does that mean to say I give intravenous iron? If somebody responds to oral iron, that means their body was crying out for iron and it will be absorbed. Therefore, there's probably not a blockade of iron at the enterocyte. And that's helpful information to have. So one of the things which certainly with Abbott, again, another exciting development, is that using all of that information, so the information from all of the tests that we do that potentially will reflex test. So if you have an anemia with a hypochromia, you get a ferritin, or you will get a transferrin saturation, or you will get a blood film. Effectively, it's using algorithms, it's using evidence from the literature to build up a plan of attack. If the samples are there, they can reflex test and add on. So that I see as the future development of all of our hematology analyzers, not just doing scans of blood films so that all of those cells are being looked at, but it's also using the raw data that comes off of the blood count combined with the chemistry results to create an overall picture that you then go into an algorithm-based clinical decision software. And this is just the example of the Excel spreadsheet using male and females, using MCH, MCR, all of those kind of things to eventually kind of say, this is the likelihood or this is less likely than something else. So an exciting development, and hopefully one that you will see in your own laboratories in the future. And you use this data, you use this information to help give you guidance to things which traditionally were not dealt with very well. People coming into hospital anemic preoperatively. Well, optimization is key. If you can optimize them, improve their hemoglobins, then they will have less reliance on blood product support, and morbidity associated with the operation may well be reduced. So we use the MCHR to guide us on giving intravenous iron preoperatively. If their ferritin is normal, they will get intravenous iron if there is evidence of iron restriction. So it's not just trying to optimize people who are clearly iron restricted on the basis of absolute iron deficiency, but what we know from CKD is that if we give them intravenous iron and their ferritin is normal, if they're going to have a 500 mil blood loss, they're going to have a requirement for iron later on. And if they're already iron restricted, it's going to be worse. So you give it preemptively. So thank you very much. I hope I've given you a nice whistle-stop tour of how our machines are fascinating and what the information they can give us, and that you'll be hopefully able to develop those things within your own laboratories. And I think now I'm able to pass on to the question zone.
Thank you, Wayne. And I am sure everyone will agree that that was a fantastic presentation. So yeah, I'm going to have a look at the questions that have been submitted. So we have a question from, it's an anonymous attendee, and they have asked, would you recommend ZPP rather than CRP plus ferritin in cases where inflammation is suspected?
So I'll point them to the latest guideline that's just about to come out in publication, which basically says ZPP is difficult to support. It's such a difficult test to do in most laboratories. It's very long-winded. There was a good evidence base for the use of it in children, but I think our full blood count machines are so good now that actually if we've got a combination of the red cell analytes, and if you can quality control those, and you've got CRP and you've got ferritin, I think you're more likely to gain more information from those rather than, say, adding another test, which is rather more difficult for colleagues within the laboratory to do. There are some people who say ZPP is great, and I get that. And if they're able to QC it and they're able to get good results on it, fine. But I think most of us would struggle with it because not many of us are doing it these days.
Thank you. And I have another anonymous attendee who's asked, they have said perhaps this is a silly question, but we know there are no silly questions here.
No, definitely not.
And they're asking, I think this is one for both of us though, unwittingly they haven't realized this, but is there an EQA scheme for the Retic-HE, or is there one in the pipeline?
Yeah, so that the data that I showed you earlier on was the pilot. So yeah, Yvonne was involved with this and did a fantastic job. We got it all sent out to a whole load of laboratories. I didn't show you the Beckman-Coulter because Beckman-Coulter used something akin to the size distribution. But yeah, I'm quite keen for us to work with BC around that area, because I think all analyzers potentially are capable of doing it. But yes, we need to have a QC program which allows you to report it. So yes, once we've gone through the process of screening the data, writing up the results and publishing it, then of course the next step will be to create a bona fide scheme around the reticulocyte hemoglobin, so you can then put it back in scope for your UCAS accreditation to agree, yes, that's sufficient. You can now report it to your clinical teams.
Thanks, Wayne. Oh, hang on, my questions are disappearing because I think they're being answered in the chat. Okay, so I have an anonymous attendee again. So would you routinely run a TIBC?
No. No. In all fairness, I think it kind of depends. I mean, we don't have a high prevalence of thalassemia in the Southwest, so we are not going to get that as a confounding variable. I've said it in any piece of information that helps guide you, gives you a bit more information to the jigsaw of the clinical picture, fine. I don't think, if you're thinking, is this anemia chronic disease, is this absolute iron deficiency, your transferrin saturation is not going to give you the answer to that. But it could be used in the patient where you're not sure that they've got thalassemia and you potentially want to give them an iron therapy. But then you're going to be using it in an inflammatory process where you want to either optimize or where you want to give intravenous iron. The flip side is, of course, you should always do a transferrin saturation if the ferritin is high. So, more than 200 in a woman, 250 in a man, but you're looking for a different reason there. You're looking for screening for genetic hemochromatosis. So yes, to that side of things, but not routinely. No, I think we need to perhaps be a little bit more scrutinizing of who we do our iron studies on, because a lot of people don't get what they mean. There's a significant diurnal variation. It's only telling you at that point in time what the trafficking of iron is doing. If you give somebody iron therapy and they're iron deficient, you'll suddenly see an upspike in the transferrin saturation. So that can confuse people as well. So it really does, and you don't know that without asking the question. So it'll come through and you, what does that mean? But the clinician will say, oh yeah, I started them on iron a few days ago. Unsurprisingly, therefore, it goes up. So it's got to be reflective of what's been happening recently.
Thanks, Wayne. I was going to say, when you said no, you sounded a bit unsure then, so I'm glad you went on and explained that. So we've got a question from Mustafa. He's asked, what's the level of confidence can we give from Retic-HB?
Yeah, so Mustafa, that's a good question. It's about defining those cutoffs, I think. And certainly with CHR, there's pretty good evidence that less than 29 is suggestive of iron restriction. We did that comparative study of CHR versus MCHR, and actually what we found was that the MCHR was slightly lower, but the data that we've got back from the QCs suggests that actually they're pretty much the same, that the CHR might be slightly lower than the RET-HE, and the RET-HE is very similar to the MCHR. So the latest guideline from the BSH is going to suggest that there is evidence of iron restriction with less than 29 picograms. And I think the lower it goes, the more confident you can be. But look, what we're saying is that that's if you've got somebody who's got you're not sure with the ferritin and they've clearly got iron restriction on the basis of the MCHR, that's telling you something. And that's what it's all about. It's using that information, not saying that's what it is, but I've got this clinical picture, I've got this blood picture, and the reticulocyte hemoglobin is just adding a little bit more information to that picture that you're already building.
So Marcus has said, amazing talk, but what are we
doing?
Thank you. What are we doing in the children's hospital setup? Ferritin is not so useful. Are the new red cell parameters more useful in the pediatric cases?
I would suggest that if you're really keen, then the data needs, there's an evidence base to be built around that. So it's ripe for the development. I'm talking about adults here. I'm an adult hematologist. So in terms of data from pediatrics, yeah, if there is some suggestion worldwide related to it, but UK, I haven't seen an awful lot, but it would be great if you're in a pediatric hospital and you're keen to have a look, please have a look, because potentially that data would be useful to, there's no reason to think that it wouldn't be, but as you know, as you go through development of childhood, the MCH and the MCB are often very low during those periods of development, growing, and then eventually it normalizes. So it's not unusual to have low values during the developmental phase of childhood. And all children are going to be intolerant to too much iron if you can't give them too much iron. But yeah, it's ripe for looking at the study, I would suggest.
Thank you for that. We have an anonymous attendee who has asked, have you looked at these parameters in cold antibody patients? Are they any different when kept at 37 degrees, or is there some variability because of the temperature?
Temperature, probably not. No, I think from what we've done, and no, we haven't done any formal studies, but of course we put samples on the bench and we've repeated them. I haven't published that, but no, room temperature versus cold, no, there's probably no difference between because don't forget, you're actually looking at the content of hemoglobin. You put a cell on the side, it will swell during warm temperatures, but it won't change what the content is to any significant degree. I don't know the answer to cold ags, to be honest with you. I don't think, I don't recall anybody having looked, but as long as you can clearly define a reticulocyte, because don't forget, they're clearly saying what the reticulocytes are by the definition of them having RNA, and that's where you get the information from. So as long as you clearly identify them, I shouldn't have thought it would make much of a difference.
Now, Wayne, you mentioned about the Beckman-Coulter machines before and the fact that they use research parameters. So can you describe what a lab should do if they want to use a research or a new parameter where there is no EQA?
So there's nothing to stop anybody from having a result and then giving a result to a clinical team, as long as you've got an evidence base to do that. But ultimately, you need to tell your users that that does not fall under, if you've got UCAS accreditation of your laboratory, but you're doing a test that does not have a QC around it, you have to tell people there is no QC around it, okay? We all do that. We've all got tests, you know. Glandular fever screening, for example, it's a very good example. You know, we don't have an EQA presently for glandular, but we all report it, don't we? Because it's just one of those things which we do. We've been doing it for ages, but ultimately, somebody has to take clinical responsibility for that result. That's what we've been doing with reticulocyte hemoglobin for a long time now, and the evidence base has been built up around the guidance. The guidance is still there, and has been developed alongside the evidence base. Now we need to get right the quality assurance around it. So it's more about making sure you are satisfied, even if it's sharing across laboratories of some kind of scheme until there's a full scheme available. At least you're looking at how you can have a good QC around it.
Yeah, it sounds like there's scope for just like inter-lab comparisons there as well from what you described.
Yeah.
I'm just going to pull you up as well because we do now have a scheme.
Sorry, we do. We do. Yeah.
We're all gasping here at NEQAS Haematology.
When did that start? All right. We do have one. Yeah. Yeah. Barbara's going, oh, for God's sake, call yourself a chairman. Oops.
Oh, well, I don't know. I think we've got to leave on a high now because we're going to have to just cut you off before you start discrediting any other things.
We've now told everybody that we've got an IM screen QC. So if people didn't know, they do now. So
well, this is true. This is true. We've managed to advertise our EQA scheme there. Yeah, so
but we didn't for a while, did we? We didn't
for a while. We've probably been nearly a year with it, doing a lot of work. So you know, it's been there for a little bit. Mostly started with just the UK lab, so there might be some international labs that are not aware of it as yet.
Yeah. Okay.
But we've got it published for our re-registration.
Apologies.
Well, so people can find it now. It's okay, Wayne. I'll have words with you later. We've got a question from Andy. Would you restrict transfusion with increased retics and sufficient ferritin with asymptomatic patients, hemoglobin less than 80?
So that's well, it's a clinical question, really, isn't it? I mean, if you can avoid transfusion, I mean, I up until recently, I was in charge of transfusion within Derriford Hospital, which is a major trauma centre. And yeah, if you can avoid transfusion, you should. And I spend a lot of my time telling people not to transfuse. Yes and no. Okay, so there are clinical indicators that might override that. A good example would be somebody who's got significant cardiorespiratory disease, who's got evidence of ischemic change on an ECG, or if they've got significant respiratory failure, then you might override that threshold. A threshold is only as good as you can clinically apply it to be. So you shouldn't say dogmatically, but you can suggest that it's unlikely. But you might hear somebody with a hemoglobin of 88 who's got significant cardiorespiratory disease, who's got ischemic changes on their ECG, and you think that their anemia is contributing to that, you're probably going to transfuse, in all fairness. And we do that. The difficulty is that these are the exact same group of people that are going to come into problems with the transfusion, which you're trying to avoid in the first place, isn't it? You know, the fluid overload that you go with it. So there's very good rationales. But if they've already got a reticulocytosis and they've got good iron stores, then yeah, if you can hold off, you would suggest to do so if clinically it is appropriate to do so. So you can ask that question, can't you? If they're absolutely sat up in their bed looking chipper, then no, don't. And you know, and I would clinically approve that, but there is that caveat.
So Andy has followed up with, how would MCHR help?
Well, MCHR would just tell you at that point in time. So the ferritin, you may not be able to sense check it at that time. So you might not know if it's already raised because of an inflammation. You might not get the CRP back, or you might go, it's a little bit high. But the reticulocytes, the hemoglobinization will tell you how well the bone marrow is at that point in time using the iron that it has available to it. So if it is also normal, then that would suggest that at that point in time, they are using the iron that is available to them. So it will give you maybe a little bit more ammunition to say, no, don't do that. Because if they're iron restricted with a sort of a modestly low ferritin, let's say, I don't know, 30-ish, and you don't know what anything else is going on, you might suggest actually intravenous iron is the better course of action. But it's going to take a while. It's going to take a while. I mean, iron takes a while for it to have an effect. We say that you need to check it no earlier really than 2 weeks, anything up to about 4 weeks. You're looking for a delta of ideally 10 grams or more. And if you get 20 grams, you're really, that's really well done. And of course, 10 grams per liter is kind of like giving a bag of blood.